Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the ECG part of the cardiology, that is the abnormalities of the P wave. So if you see the P wave, that is the first wave within the ECG, and what does this P wave represent? This P wave, it represents the atrial depolarization, right? So that is the importance of the P wave, right? It is representing the atrial depolarization, and it is the first positive wave in the sense the wave which is present above the isoelectric baseline. Now if you take this P wave which is due to atrial depolarization, we will try to dissect it. It has two halves, right? If you see the P wave, it has two halves. So this is considered as the first half and this is considered as the second half of the P wave. Now what does the first half of the P wave represent and what does the second half of the P wave represent? First half of the P wave, it represents the right atrial depolarization, and second half of the P wave represent the left atrial depolarization. So if there is any abnormality in the right atrium, you will have abnormality in the first half of the P wave, and any abnormality in the left atrium, you will have the abnormality in the second half of the P wave. Okay, so most of the times, or in majority of the leads, the P wave, it is a monophasic wave. Okay, so P wave, it is considered as monophasic wave. Now what do you mean by this word monophasic wave? That means the entire morphology of the P wave, which is smooth, it is present above the isoelectric baseline. That is what is called as monophasic wave. But in certain leads, there is, or in one particular lead, I can say it is a biphasic wave. That means half of the P wave is above the isoelectric baseline and half of the P wave is present below the isoelectric baseline. Now let me tell you in which particular lead. Okay, so in which of the following lead the P wave is biphasic? Lead 2, lead 3, lead AVR, lead V1. So right now if you see the concept of the biphasic P wave, so this is how the biphasic P wave will be. In this biphasic P wave, the one which is present above the isoelectric baseline, that tells you about right atrial depolarization, and the one which is present below the isoelectric baseline, that tells you about the left atrial depolarization. Okay, now so in which of the following leads the P wave is biphasic? That is in lead V1. In lead V1, the P wave is biphasic. Let me show you that particular ECG strip. Right, so this is your lead V1. In this lead V1, you can see this is the representation of right atrial depolarization, and this is the representation of the left atrial depolarization. That this is what is called as the biphasic P wave. Now let me also try to tell you the concept why you get the biphasic P wave in lead V1. Now if you see this image, right, the basic concept in the ECG is like when the electrical activity is moving towards the electrode, you will have a positive complex. When the electrical activity is moving away from the electrode, you get a negative complex. That is a basic rule of the ECG. So you take this lead V1. So in the lead V1, whichever is being placed, so where is this lead V1 being placed? It is placed in the right side in the parasternal area. Okay, and this particular lead V1, it picks up the electrical activity of the right atrium directly. So the electrical activity of the right atrium, it is towards lead V1. So that is the reason why you get a positive complex. Okay, then you take the depolarization of the left atrial activity, it is slightly away from lead V1. So when the direction of depolarization of left atrium is away from V1, so you get a negative complex. So this is your right atrium and this is the left atrium. So this is the concept of why you are having the biphasic P wave in lead V1. But as we progress from V1 to V6, you will have the monophasic wave. Okay, right. So I said you, like in majority of the leads, the P wave, it is a monophasic wave and it is present above the isoelectric baseline, or rather like I call it as like it's a positive wave. But there is one exception for this. In one particular lead, the P wave is negative. Okay, so in which particular lead the P wave is being negative is, that is in lead AVR. Okay, so if you take in lead AVR, the P wave, it is negative. Now, what is the concept of this? Why in AVR the P wave is negative? The concept is that if you take the AVR, where exactly is the representation of the AVR? So this is your AVR in the hexaxial diagram. So AVR, it is augmentation of the right arm, right? Now the point is the electrical activity or the direction of depolarization is moving away from the AVR. So this is your SA node, from here the electrical activity is moving towards the apex. So the electrical activity is moving away from your AVR. So when the electrical activity or direction of depolarization is moving away from AVR, so in lead AVR, how will be your P wave? The P wave, it will be negative. Let me show you here. So this is your lead AVR. In this lead AVR, you can see this. This is the P wave, right? This is the P wave, which is a negative wave. So now you see the basic morphology of the P wave. It is a monophasic wave. It is the one which is present above the isoelectric baseline. In almost all the leads, it is a positive wave. And exception is in lead V1, it is biphasic, and in lead AVR, it is a negative wave. Okay. So this is about the basic morphology of the P wave. Then followed by that, normal P wave axis is approximately 90 degrees, approximately 60 degrees, approximately 120 degrees, approximately 30 degrees. So if you take the normal axis, so the axis we take lead 2 into consideration because that is considered as the rhythm strip. So if you take the normal P wave axis, the normal P wave axis, okay, so if you see this is the SA node, from the SA node the electrical activity is moving towards your lead 2. So where exactly is your lead 2? It is present at 60 degree axis. Okay. So if you take the normal axis, it is approximately 60 degrees. That is the normal axis of the P wave, right? So P wave represents what? It is a wave of depolarization. And you also need to know at the same time what will happen to the wave of the atrial repolarization. So if you take the wave of atrial repolarization, you don't see that particularly in the entire ECG complex. Why? Because the wave of atrial repolarization, it has a small amplitude, right? The wave of atrial repolarization, it has a smaller amplitude. And this particular wave of atrial repolarization, which is having a smaller amplitude, that is masked by the QRS complex. Now, what is that amplitude of atrial repolarization? Let me just show you this important question. Amplitude of atrial repolarization is less than 50 microvolts, less than 100 microvolts, less than 1 millivolt, less than 1 volt. So the voltage of atrial repolarization is less than 100 microvolts, okay? Because it is having a very lesser amplitude, this particular less than 100 microvolts, that will be masked by the QRS complex. And that is the reason why you don't have specifically the wave of the atrial repolarization. Now, after having discussed about like depolarization and repolarization, now let us just go on to the discussion of the amplitude and as well as the duration of the P wave of a normal P wave. So if you see this question here, amplitude and duration of the normal P wave in the limb leads is, the options are less than 1.5 mm and less than 120 milliseconds. Second option are less than 2.5 mm, less than 120 milliseconds. Third option less than 2 mm, less than 210 milliseconds. And fourth option is less than 3 mm, less than 110 milliseconds. So if you take the amplitude and as well as the duration, remember the duration is fixed. The duration usually does not change, except for in the abnormalities associated with the left atrium. So how much will be the duration? That is 120 milliseconds. But the amplitude, so the duration either you take in the limb leads or you take in the precordial leads, the duration will be the same. That is less than 120 milliseconds. But the point of difference is in the amplitude. Okay. So if you take the amplitude in the limb leads, the amplitude is less than 2.5 mm. But in case of the precordial leads, if you observe, right? So in case of the precordial leads, the amplitude is less than 1.5 mm. So precordial leads are nothing but V1 to V6. So if you see the, yes, now the amplitude is around 2.5 mm and the duration it is around 120 milliseconds. So this is in the limb leads, whereas you take in the chest leads. So what did I tell you in the chest leads? So in the chest leads, right, in the chest leads, the amplitude is how much? It is less than 1.5 mm. Okay, so where it is occupying less than 2 small boxes in the amplitude, but the duration either in the limb lead or in the chest lead, it is the same, that is less than 120 milliseconds. All right. Now let us take up the discussion of the abnormalities of the P wave. Until now, what I have discussed is only the normal part of the P wave. Now let me take up the discussion of the abnormalities of the P wave. So you see a 57-year-old woman who presents with pedal edema, and on examination, there is not only pedal edema, there is also tender hepatomegaly. What do you think is the diagnosis? The options are mitral stenosis, tricuspid stenosis, aortic stenosis, and mitral regurgitation. Now, if you closely observe, she is like, 57-year-old female, presented with pedal edema, swelling of the legs. And on examination also, there is a bilateral pitting type of pedal edema. Along with that, there is tender hepatomegaly, right? So, presence of tender hepatomegaly, presence of bilateral pitting type of pedal edema. So both of these, they are the features of right-sided heart abnormality rather than left-sided heart abnormality. So there itself you get a clue in the history itself. Now based on the ECG finding, like you should be able to fix the diagnosis. So always in which particular lead you need to observe the P wave first. The P wave, it has to be observed first in lead 2. So lead 2, it is considered as rhythm strip. Okay. So in lead 2, you need to observe or you need to look for the P wave first. Then we will look for the P wave in other leads also. And if you take the P wave here, right? So how is the P wave that is appearing to you? The P wave, the amplitude is increased and it is like peaked. That is how the P wave is. So if you clearly measure the amplitude of the P wave, it is more than 2.5 mm, right? It is more than 2.5 mm. So it is occupying more than 2.5 small boxes. Okay. So now the individual is having the P wave which is being peaked and amplitude being more than 2.5 mm. Now what is this particular type of P wave called as? This particular type of P wave, we call it as the P pulmonale. Now, the point is in which clinical condition you come across this particular P pulmonale. So, you come across this P pulmonale in patients with the tricuspid stenosis. So, in patients with tricuspid stenosis, what will happen is there will be right atrial hypertrophy. So, because of right atrial hypertrophy, the depolarization activity is more. So, the amplitude of the P wave of the first half is also more. And that is the reason why you are getting that particular P pulmonale, right? So, yes, right. So, this is what is your P pulmonale, right? Now, whenever there is right atrial enlargement, what did I tell you? It is the first half of the P wave that gets affected. Now, the point is, okay, is the duration changing? No. The duration will remain same, that is less than 120 milliseconds. It is only the amplitude which will change in case of right atrial hypertrophy, right? Now, the next important point is in lead V1, we have discussed we will have a biphasic P wave. So, if it is a biphasic P wave in lead V1, what will be this right atrial abnormality in lead V1? So, yes, you see this. Now, whenever there is right atrial abnormality, the first half of the P wave in lead V1 gets changed. So, the amplitude of the first half of the P wave will be more than 1.5 mm. Right? Normally, it is around 1 mm. Right? Normally, around the first half of the P wave in lead V1, it will be around 1 mm. But in case of in case of right atrial hypertrophy, the amplitude of the first half of the P wave will be more than 1.5 mm. Okay. So that is what is the abnormality of the right atrium in lead V1. Right. Now, after having discussed about the right atrial abnormality, let me also just give you a quick criteria also. Right. The criteria is that number 1, you will have P pulmonale. Criteria for what? Criteria for right atrial hypertrophy. So P pulmonale, where the amplitude is more than 2.5 mm in the limb leads, or if you take it in the form of voltage, it is more than 0.25 millivolts. Okay. Then the initial part of P wave in lead V1, how much that will be? That will be more than 1.5 mm in lead V1, right? Then what will happen to the axis? What did I tell you? The normal axis is around 60 degrees, but here there will be a rightward shift of the P wave. Okay, so a slightly rightward shift. So how much will be the P wave axis here? The axis will be around plus 75 degrees. Okay, that will be the axis in case of right atrial hypertrophy. So this is a criteria for right atrial hypertrophy, right? And one more important point is, if you take the area under the initial positive portion of the P wave, the area under the initial positive portion of the P wave in lead V1, it will be more than 0.06 millimeter second. So that is what is the area under the initial positive P wave in lead V1. So this is the criteria for the P pulmonale or the right atrial abnormality. Now, and at the same time, you need to know what are all the various conditions where you come across this P pulmonale, or what are all the conditions which will cause right atrial hypertrophy. So if you see this question here, following are the causes of the P pulmonale except. The options are pulmonary arterial hypertension, tetralogy of Fallot and pulmonic stenosis in right to left sided shunts, tricuspid stenosis and the aortic regurgitation. So remember, P pulmonale is telling you about right atrial hypertrophy. So in pulmonary arterial hypertension, you will have right atrial hypertrophy. In tetralogy of Fallot, you will have right atrial hypertrophy. In tricuspid stenosis also, you will have right atrial hypertrophy. But in aortic regurgitation, remember, what you will have is left ventricular dilatation. Okay, but it does not affect your right atrium. Which one? The aortic regurgitation. So apart from these three conditions, pulmonary arterial hypertension, tetralogy of Fallot and tricuspid stenosis, one more condition where you can have the P pulmonale is in patients with the cor pulmonale. So even in patients with cor pulmonale, you will have right atrial hypertrophy causing P pulmonale, right? So that is about, the abnormalities of the right atrium and what will be the changes in the P wave in the ECG. Now let us move on to the abnormalities of the left atrium, like what will be the changes that you will see within the ECG because of abnormalities within the left atrium. So, right. So you see this question, this patient should undergo treatment with adrenaline, surgery, that is PBMV. Third option, treatment with digoxin. Fourth option, surgery, that is coronary artery bypass graft. Okay. Now, what is that this particular patient should undergo? So if you clearly observe here, what is that abnormality you are having in the P wave? The abnormality that you are having in the P wave here is the P wave, it is of M-shaped, right? And if the P wave, if it is of M-shape, we call this as P mitral, right? We call this as P mitral. Now, where do you come across this particular P mitral? You come across this P mitral in the clinical scenario of mitral stenosis. Okay. So in mitral stenosis, there will be left atrial hypertrophy. So whenever there is left atrial hypertrophy, you come across this what is called as P mitral. Now, whenever there is mitral stenosis causing left atrial hypertrophy, what is the treatment that the individual has to undergo? One of the treatment option is, that is PBMV. Okay. So which is nothing but your percutaneous balloon mitral valvotomy, right? And the balloon that we use here is the Eno balloon, right? The balloon that we use here is the Eno balloon. Okay. Now, the point is, what will be the criteria to call it as left atrial hypertrophy on the ECG? So I said you, like the P wave, it will be of M shape, which is called as P mitral. Now the point is, like in case of P mitral, it is the duration which will change. The amplitude will remain same, but the duration of the P wave will be increased. What is the normal duration of the P wave? That is less than 120 milliseconds. But in case of mitral stenosis causing P mitral, the duration of the P wave, it is more than 120 milliseconds, right? The duration of the P wave will be more than 120 milliseconds. That is what is called as the P mitral, right? Now, another important thing in the criteria is that you are having this particular M shape, right? Okay, you're having this M shape. Now, to call it as P mitral, right? To call it as P mitral, or in case of left atrial hypertrophy, what will happen to, right? In case of left atrial hypertrophy, what will be the duration between the two peaks of the M? Like for example, this you consider as the first peak of M, and this you consider it as the second peak of M. So the distance between these two peaks, it should be more than 40 milliseconds. That means it should be more than one small box. Not in the normal scenario, in case of left atrial hypertrophy, right? In a normal scenario, you don't come across this P mitral at all. But in case of left atrial hypertrophy, the duration between the two peaks, it should be more than 40 milliseconds. So that is another important criteria to call it as, right? That is another important criteria to call it as the P mitral, right? Now, another important point is like what, see, definitely in your lead 2, which is considered as rhythm strip, you'll have this P mitral whenever there is left atrial hypertrophy. But the point is, whenever there is left atrial abnormality, what will be the morphology of the P wave in lead V1? In lead V1, what will be the change? Okay, now let me discuss that. So let me just, summarize the entire criteria of the left atrial abnormality. Number 1, the individual will have the individual will have the prolonged P wave duration, and this prolonged P wave duration, it will be for more than 120 milliseconds in lead 2, right? In lead 2. And the next important is the distance between the two peaks, right? The distance between the two peaks, how much it should be? It should be more than 40 milliseconds, right? And the next important thing is the lead V1. In lead V1, you have the biphasic wave, right? Okay. And which part of your P wave in lead V1 represents left atrial abnormality? That is the second half. So this is what is the representation of the left atrial depolarization. Now, in case of left atrial hypertrophy, what will happen to this negative component of left atrium? The depth of negative component of the left atrium, it will be wide and as well as deep as well, right? And how much wide and how much deep is a criteria. Okay. So the duration, right? The duration of this negative component, only negative component of lead V1, how much it should be? It should be more than 40 milliseconds, right? It should be more than 40 milliseconds. And what should be the depth? Depth should be more than 1.5 mm for calling it as left atrial hypertrophy. Then what will happen to the axis? So you will have leftward shift of the P wave, right? You will have leftward shift of the P wave. Now this leftward shift of the P wave, how much will be the exact axis? That is around -30 to -45, right? -30 to -45. So this is what is the criteria to call it as the left atrial hypertrophy. Now we have few more indices called as Morris index and as well as Macros index. I'll be discussing about that. Okay. Now, so this is about the criteria for the left atrial hypertrophy. Now let me also just tell you this duration more than the second half of the P wave in lead V1, the duration being more than 40 milliseconds and depth being more than 1.5 mm. What do we call this as, right? So it is around, let me just make a small correction here. So this will be around more than 1 to 1.5 mm depth, okay, to call it as left atrial hypertrophy. Now what do we call this as? So we call this as the P terminal force. Okay, this we call it as the P terminal force. So P terminal force means where the negative component of the P wave, it is deep and as well as wide, right? Now this is about the criteria to call it as the left atrial hypertrophy. Now, in this, let me discuss about what is called as the Morris index and as well as the Macrous index. Okay. Now, what are these two indices? The question is like, what is the Macrous index for the mitral stenosis? The options are 1, 1.6, more than 1.6, less than 1. Okay. First of all, let me discuss about both of these indices, Morris and as well as Macrous index, and then we'll come back to that question once again, right? Now, you take the Morris index first. So, Morris index tells you that the negative component of the P wave in lead V1, you see this. Okay, the negative component of, the negative component of the P wave in lead V1, the duration, this particular duration, it should be more than 40 milliseconds. The duration should be more than 40 milliseconds. That is one thing. And the depth should be more than 2 mm to call it as left atrial hypertrophy. So this is what is called as the Morris index, This is what is called as the Morris index. Okay. Now, then what do you understand by this word Macrous index then? Macrous index, let me tell you, it is the measurement of P by PR segment. It is the measurement of P by PR segment. Okay. That is the duration of the P wave to that of the PR segment. Okay. What is its normal value? What will happen in left atrial hypertrophy? And what will happen in right atrial hypertrophy? Let me discuss that. So this is what is your, the way how you need to measure. So you have, this is your A of your P wave, that is the beginning of the P wave. Then this is B, that is the end of the P wave. Then you have the isoelectric baseline, and this isoelectric baseline, this is what is nothing but your PR segment. This is what is nothing but your PR segment. Okay. So the PR segment, it is from the end of the P wave to the starting of the QRS complex. That is what is nothing but your PR segment. So the point is, in order to calculate this Macrous index, it is AB, which is nothing but the duration of the P wave, by BC. Okay, that is what is nothing but P by PR segment. That is what is nothing. That is how you need to calculate the Macrous index. Now, what is the normal Macrous index? If you take the normal value of the Macrous index, the normal value is around 1 to 1.6. The normal value is 1 to 1.6. Now, whenever there is mitral stenosis, what will happen to the duration of the P wave? The duration of the P wave will be increased. The duration of the P wave will be increased whenever there is mitral stenosis. That means what will happen to your AB value? AB value increases in the mitral stenosis. So when the AB value increases in mitral stenosis, the normal value is around 1 to 1.6. So in mitral stenosis, it will be more than 1.6. In mitral stenosis, it will be more than 1.6. Okay. Whereas you take in patients with tricuspid stenosis, where you have the P pulmonale, there the value of the Macrous index will be less than 1. So that is about your Macrous index. Morris index tells you about the depth of the P terminal force and as well as the duration of the P terminal force. Macrous index tells you about the P by PR segment. So if you see this question back again, what is the Macrous index for mitral stenosis? That will be more than 1.6. So this is how you need to make up the left atrial abnormality. Now we have discussed the normal P wave, right atrial abnormality, left atrial abnormality. Now whenever there is biatrial abnormality, what can be the change? Okay, let me summarize everything here. So if you closely observe all these, it is a comparison in normal right atrial abnormality, left atrial enlargement and biatrial enlargement. So if you see the normal P wave in lead 2, what did I tell you? It is a monophasic wave. Whereas in lead V1, what is that we have discussed? It is the biphasic wave. right? And whenever there is right atrial abnormality or right atrial enlargement, you will have what is called P pulmonale, right? And in lead V1, what will happen? The initial part of the P wave, that is the positive component of the P wave, the amplitude is more, right? Whereas in left atrial enlargement, you will have the P mitral. You will have P mitral. And if you observe the negative component of the P wave in left atrial enlargement, you will have what is called the P terminal force. And you see in case of biatrial enlargement. In biatrial enlargement, you will have both. That is P pulmonale will be there and P mitral also will be there. That is what you will observe in case of biatrial enlargement. And in the same way, in lead V1 also, the first half of the P wave also you will have, the amplitude being greater and sharp. And even the second half of the P wave in lead V1, the depth is more and the duration is wide. That is what you will observe in case of biatrial enlargement, right? Now, until now, what we have discussed in the abnormalities of the P wave is when there is right atrial enlargement, what will be the change in the P wave? If there is left atrial enlargement, what is the change in the P wave? That is what we have discussed until now. Now, let me take up the abnormality of the P wave depending upon, the rhythm and depending upon where the depolarization of the entire heart is starting from. So the question is, like this particular ECG strip has been given to you and he is asking you about the rhythm. Is it like normal sinus rhythm? Is it like ventricular rhythm? Is it like irregular rhythm? Or is it like accelerated junctional rhythm? So I'll just try to zoom up this ECG wherein you can appreciate it in a better manner. Okay. So now you see in which particular lead we have discussed that you need to look for lead 2, your P wave, you need to look it in the lead 2 because lead 2 is considered as a rhythm strip. Now, if you clearly observe there, how is the P wave? The P wave, it is negative wave. Okay. The P wave, it is negative. You can see this, right? Now, in which clinical scenario you will have the P wave being negative in almost all the leads. Okay. So you see almost all the leads in the sense in 2, 3 AVF, you can see that the P wave is being negative. Now, which conditions you come across this negative P wave in 2, 3 AVF? You come across this in case of accelerated junctional rhythm. Now, let me try to explain you the concept here, right? Why you get a P wave in case of the accelerated junctional rhythm. Now, in case of the accelerated junctional rhythm, you need to understand that it is not the SA node which is acting as a pacemaker. It is the AV node which is acting as a pacemaker in case of the junctional rhythm. So when the AV node is acting as a pacemaker here, once the impulse generates in the AV node, simultaneously it will be moving to your ventricle and simultaneously it will be moving towards atria also, right? Simultaneously it will be moving towards atria also. Now, if you see the direction of depolarization of the atria, right? If you see the direction of depolarization of the atria in case of junctional rhythm, the direction of depolarization of the atria, it is moving away from the electrode, right? It is moving away from the electrode. When the direction of depolarization is moving away from the electrode, that is atrial depolarization, thereby, you get what is called as the negative P wave. Okay, negative P wave. That is what you see in case of junctional rhythm. Now, in certain scenarios, what may happen is, now if you take this particular ECG strip, this is your P wave, this is your QRS complex, and this is followed by that you are having a spike. This is what is your T wave. Now, the point is, in certain scenarios, the P wave, it can appear, right? The P wave, it can appear after the QRS complex. You see here, after the QRS complex, you are observing the P wave. Now, when do you come across this? You will come across this in case of same junctional rhythm only. But in case of junctional rhythm, if suppose, first, if the ventricle is depolarizing, right? First, the ventricle is depolarizing, followed by that, the atria is getting depolarized. That is the point when you get this P wave after the QRS complex. You get the P wave after the QRS complex. That is what you see in case of the junctional rhythm, right? So in junctional rhythm, what you see is the inverted P waves. Right? In junctional rhythm, you get this inverted P waves. Now, this inverted P waves also, you need to know, is it like only in case of junctional rhythm you come across this inverted P waves, or do we have any other conditions also? We have that. Okay. Now, if there is inverted P waves, there are two scenarios. One is in case of accelerated junctional rhythm. Right? That is one scenario. And second scenario, where do you come across the inverted P wave is, both of these scenarios, it should be non-sinus origin. Right? In both of these scenarios, it is non-sinus origin of the P wave. But if two scenarios you come across this, one in case of junctional rhythm and the other one is in case of ectopic atrial rhythm, right? Ectopic atrial rhythm. Now, how will you differentiate this, right? How will you differentiate this? Is it that inverted P wave, is it due to the junctional rhythm then? Or is it like ectopic atrial rhythm? So how do you identify that? How do you differentiate that? If suppose there is an inverted P wave, along with that, if the PR interval, if it is less than 120 milliseconds, then we consider that P wave is originating from the junctional rhythm. Okay. Whereas if along with the inverted P wave, if the PR interval, if it is more than 120 milliseconds, this we consider it as the ectopic atrial rhythm. Okay. So it is very simple to understand the concept also. Why? I'll tell you. So you take the PR interval. What does the PR interval tells you about? The PR interval tells you about actually the time taken for the impulse to move from SA node to that of AV node and passing through the AV node into the ventricles. That is what the representation of the PR interval. But in case of junctional rhythm, the impulse is directly originating from the AV node itself. When the impulse is directly originating from the AV node, where is the question of your PR interval? The PR interval will be short. That will be less than 120 milliseconds. Whereas, okay, so you see this particular, yes, this is what is the ECG of the accelerated junctional rhythm. So if you observe very carefully about the PR interval, so it is occupying two small boxes, right? The PR interval is occupying two small boxes. That means it is 80 milliseconds. Whereas you take in patients with the ectopic atrial rhythm. In ectopic atrial rhythm, right, this is the ECG strip of ectopic atrial rhythm, where you have the inverted P wave. Along with the inverted P wave, if you see the PR interval, right, how many small boxes is it occupying? It is occupying almost 4 small boxes. So that means it is around 160 milliseconds. Okay. So ectopic atrial rhythm, the PR interval will be more than 120, whereas junctional rhythm, the PR interval will be less than 120 milliseconds. Okay. Now in this question, normal sinus rhythm, right? We are very much aware of, you will have a normal P wave, then normal PR interval, and then QRS complex followed by T. Whereas you take ventricular rhythm. Okay. So in case of ventricular rhythm, how does the ECG appears? You see here. So in case of ventricular rhythm, you will observe that there is no P wave. Why? Because the impulse is originating from the ventricle. So the QRS complex will mask the wave which you are getting due to atrial depolarization. And you will have the wide QRS complex. Right? Wide QRS complex, and there is no P wave. Or occasionally the P wave can be there in the terminal portion of, you see here, in the terminal portion of the QRS complex, you can have this particular P wave. Okay, that is occasionally. That is what is your ventricular rhythm, where you will not have a P wave, wide QRS complex, because the impulse is originating from the ventricle, right? Then next point is rhythm in the ECG is best assessed in lead 2, lead 3, lead 1, AVR. So lead 2 is considered as the rhythm strip. Right, lead 2 is considered as the rhythm strip. Okay, so that is the reason why we take the lead 2 as the best lead for assessment of all the waves, right? For assessment of abnormalities of all the waves, right? Then now let me show you one more. Yes, this was your lead 2, right? Where you can observe the morphology of all the waves. Why we take lead 2 as the rhythm strip? Because the position of lead 2, it is exactly in the direction of the depolarization of the entire heart. Because it is in the direction of depolarization of the entire heart, that is the reason why lead 2 is considered as rhythm strip, right? Next, let me show you one more ECG and take up the rhythm here, right? So if you, okay, which is considered as rhythm strip, that is lead 2. So lead 2, it is usually mentioned at the bottom of this ECG. Now, if you very closely and if you very clearly observe the P wave and as well as the rhythm here, first and foremost, there is irregular RR interval. So when there is irregular RR interval, so RR interval, it is varying. You can see that here. So when the RR interval is varying, we call it as irregular rhythm, right? Irregular rhythm. Okay. Now, once you see this particular type of rhythm, immediately you should come to a differential diagnosis. What is that? So irregular rhythm is seen in patients with the atrial fibrillation. You can come across that in patients with the atrial flutter. Okay. But atrial flutter and as well as multifocal atrial tachycardia. But in atrial flutter and multifocal atrial tachycardia, there should be a variable AV block. Only when there is variable AV block, then in atrial flutter and as well as multifocal atrial tachycardia also, you will have irregular rhythm. So these are the three things that should come to your mind whenever there is irregular rhythm. Now, once you think of these three differential diagnoses, immediately you need to look for the morphology of the P wave. So if you observe the P wave here, right, very closely, if you observe, in some of the leads, there is no P wave at all. You see here in this particular strip, okay, there is no P wave at all. So the P wave is absent. And whatever the small waves you are observing here, they are considered as the fibrillatory waves. Right? They are considered as the fibrillatory waves. Now, where do you come across this irregular rhythm with the fibrillatory waves? You come across that in patients with the atrial fibrillation. So this is another important clinical scenario where you will have abnormality in the P wave, where you will, instead of the P wave, you will have what is called as the fibrillatory waves, right? Next, now I'll show you one more condition where you will have abnormality in the P wave. So that was about irregular rhythm. Then, yes, you see this particular ECG strip. So this is considered as, or this particular complex, we consider it as the complex of normal sinus rhythm. But if you take this second complex, what is the abnormality you are observing in the second complex? The abnormality that you can see is there is a wide QRS complex and there is no P wave, right? There is wide QRS complex and there is no P wave. So where do you come across this? Wide QRS complex and no P wave. You come across this in case of ventricular complexes. And we call it as premature ventricular contracture. And this premature ventricular contracture, every alternate wave is a premature ventricular contracture here. So this is a normal wave, this is a premature ventricular contracture. This is a normal wave and this is the premature ventricular contracture. This is normal and this is premature ventricular contracture. So every second beat is a premature ventricular contracture. So that we call it as the ventricular bigeminy. Right? This we call it as the ventricular bigeminy. Now, if you take the rhythm here, right? Every second is an abnormal wave. So, every second that abnormality is also maintaining the regularity. That we call it as regularly irregular rhythm. So, regularly irregular rhythm, you come across this in ventricular bigeminy, ventricular trigeminy, and as well as in case of atrial flutter and PAT, paroxysmal atrial tachycardia with fixed AV block. Remember, atrial flutter with variable AV block, irregularly irregular rhythm. Whereas atrial flutter with fixed AV block, you come across this regularly irregular rhythm. Okay, right. So that was about the rhythm and as well as abnormality in the P wave. Now let me show you abnormalities of the P wave in the atrial flutter. So in atrial flutter, you don't get the normal P wave morphology. I'll just show you the ECG of the atrial flutter. Right. So this is the ECG of the atrial flutter. So you can see this P waves. What will be the morphology of the P wave? We call it as this. We call it as a saw-toothed appearance of the P wave. Right? This we call it as saw-toothed appearance of the P wave. In detail about atrial flutter and atrial fibrillation, we have discussed in the section of the arrhythmias, right? So you can go through that atrial flutter and atrial fibrillation there. But this is the ECG, or this is the abnormality of the P wave that you come across in patients with the atrial flutter, right? Now after having discussed about the rhythm abnormalities associated with abnormalities of the P wave, now let me take up the discussion of the ectopic activities. Right, let me take up the discussion of the ectopic activities, or okay, before going on to the ectopic activities, let me tell you about one type of abnormality in the P wave that is called as MAT, that is multifocal atrial tachycardia. What exactly is that? Where do you come across that? And how do you treat that? All that we will discuss now. So if you see the treatment to be given for this patient suffering with chronic obstructive pulmonary disease, the options are cardioversion, prazosin, verapamil, amiodarone. Now, you see this ECG, let me just zoom this. Yes. Whenever you are seeing the ECG, first thing what you need to look for? You need to look for the rhythm strip. What is the rhythm strip? That will be your lead 2. Okay, that will be your lead 2. Now, because we are discussing the P wave abnormalities, directly we jump onto P wave. Okay, definitely yes, we need to read the ECG in a very systematic manner. That is rate, rhythm, axis, P wave, PR interval, QRS complex, then ST segment, QT interval, T wave, and any other abnormal waves. This is how you need to interpret the ECG. But we are discussing the abnormalities of the P wave. Let me directly jump onto the P wave abnormality. Okay, right. So if you take these P waves, they are of variable morphology, right? And how many abnormal P waves are there? Definitely it will be more than 3 P wave abnormalities, right? You can count there. Definitely more than 3 P waves are abnormal. Okay, there's no doubt in that. And along with this, more than 3 P waves being of abnormal variable morphology, if you calculate the heart rate in this patient, it is more than 100 per minute. Right, the heart rate is more than 100 per minute. So more than 3 P wave variable morphologies and heart rate more than 100 beats per minute. What is that called as? That we call it as multifocal atrial tachycardia. That we call it as multifocal atrial tachycardia. And multifocal atrial tachycardia is one of the very, very important abnormal rhythm or abnormal ECG. You come across this in patients with the COPD. So in COPD, if the question is asked like what will be the abnormal rhythm, that will be MAT, multifocal atrial tachycardia. Then how do you treat these patients? Remember, in COPD, you cannot give the beta blockers, right? Usually they are avoided. The best drug here will be the calcium channel blocker, that is verapamil. Okay. Now, what is the mechanism of this MAT? Mechanism of the MAT is that because in patients with COPD, they develop what is called as the cor pulmonale. So, as a consequence of the cor pulmonale, there will be development of right atrial hypertrophy. So this hypertrophied right atrium, that will be arrhythmogenic, right? It will be sending abnormal impulses. I'll show you that. Okay, you see this. So in this atria, what is that you're observing? There are multiple pacemaker activities which is happening within the atria itself. So whenever there is multiple pacemaker activity throughout the atria, each impulse will have the variable morphology of the P wave. Okay, that is what is called as the multifocal atrial tachycardia. So this particular atrial activity, one morphology of the P wave. This particular atrial activity, one morphology of the P wave. This particular atrial activity, another morphology of the P wave. So that way you will have more than 3 different P waves. Along with that, the heart rate more than 100 per minute. This we call it as the multifocal atrial tachycardia. And these patients with multifocal atrial tachycardia, let me tell you here, the SA node is not pacing. It is the different parts of the atria which is pacing here. Second point, several groups of excitable cells in the atria compete to pace the heart. And whichever is quick, that will take over the entire rhythm of the heart. And MAT has at least 3 or more different shaped P waves. That is what we have discussed. And it is the one with irregular rhythm and heart rate above 100 beats per minute. And lastly, these patients with MAT, they'll have irregular PR, irregular RR and irregular PP interval will be there. That is what you will observe in patients with the MAT. That is multifocal atrial tachycardia. Okay. So that is the criteria for MAT. That is a criteria for MAT. So let me just do a quick recap. Number 1, heart rate more than 100. Irregularly irregular rhythm. More than or equal to 3 distinct P wave morphologies. Right? Your PP interval, PR interval, RR interval will be completely variable. And some of the P waves, you know, they are not conducted even. Because which particular P waves are not conducted? The impulse which is weak, it may not get conducted into your ventricle itself. So the P wave is not followed by the QRS complex. So this is about the criteria of multifocal atrial tachycardia. Now at the same time, you also need to know what will be the clinical features of the MAT. So most of these patients, what did we discuss? Right? They are of the COPD patients, or there would be history of the congestive heart failure. Now whenever there is any arrhythmia, what will happen to the cardiac output? In any form of the arrhythmia, the cardiac output will be reduced. So thereby what will happen to cerebral perfusion? That will be reduced. So the patient will have lightheadedness. Right? The patient will have lightheadedness. Okay. Second important thing is, because of the arrhythmias, right? Because of the arrhythmia, there will be palpitations. And once their cerebral perfusion is decreased, the individual will develop what is called as the syncopal attack. The individual will develop what is called syncopal attack. And on examination, you will notice that there is tachycardia. Right? On examination, you will notice that there is presence of tachycardia. And because the cardiac output is decreased, what do you think will happen to the blood pressure? The blood pressure also will be reduced. Okay. So this is what is the clinical manifestations and as well as the examination findings in patients with multifocal atrial tachycardia. Then, how do you treat these patients with multifocal atrial tachycardia? First and foremost, you need to manage the respiratory failure, because these patients of COPD, they may go into a state of respiratory failure. So quickly supplement the oxygen to the patient, right? And try to maintain the saturation. Next, very important is the cardioversion may not be helpful due to hypoxia. So once you are managing the respiratory failure, the oxygen levels have to be improved and saturation should be adequately improved, right? In case of COPD, we want a saturation roughly around 90%, okay? And now, in order to reduce the tachycardia, in order to reduce the pacemaker activity of the atria, different parts of the atria or different portions of the atria, so the drugs that we give is verapamil. Right, the drug that we give is verapamil, or we give these beta blockers. Okay, so what will be that beta blockers? That particular beta blocker will be metoprolol. right? That will be metoprolol, okay? But the only point is, the metoprolol is avoided in patients with COPD. The alternative will be the verapamil. But if the multifocal atrial tachycardia, if the etiology is other than COPD, then you can give this beta blocker, that is metoprolol. Now let me tell you what are the other etiologies that can cause multifocal atrial tachycardia. So accordingly, you have a question: drugs causing multifocal atrial tachycardia. The options are digoxin toxicity, theophylline toxicity, atropinization, opioid poisoning. So the drugs where you come across this MAT is in case of theophylline toxicity. So if you see, most common cause will be COPD, right? The drug toxicity will be theophylline toxicity, and then even sepsis can also cause multifocal atrial tachycardia. So if the etiology of the MAT, if it is other than COPD, then you can give this cardioselective beta blocker, that is metoprolol, okay? And we have the few more drugs, few more conditions which can cause MAT. The other conditions are like hypoxia and as well as the hypercarbia, which can be seen in COPD patients. Then right, next is the beta agonists can also cause this multifocal atrial tachycardia. Then electrolyte abnormality in the form of hypokalemia and as well as hypomagnesemia. So hypokalemia and hypomagnesemia, even they also can cause this multifocal atrial tachycardia, right? So this is about the etiologies where you come across this MAT. And let me show you an ECG with the P wave abnormality. So you can see here, what is that you are observing very clearly? You can see the P waves of sawtoothed pattern. So where do you come across the P waves of sawtoothed pattern? Right. So where do you come across the P waves of sawtoothed pattern? Right. You come across that in patients with the atrial flutter. So remember, what will be the ECG features of atrial flutter? Atrial flutter, it is a narrow complex tachycardia. It is not wide complex tachycardia. It is narrow complex tachycardia. Narrow complex in the sense the QRS complex is normal, right? Then next is what will happen to the atrial activity. So if you take the atrial rate, that will be around 300 beats per minute. That will be around 300 beats per minute. And if you take the P waves, what you have is the flutter waves, right? You have what is called the flutter waves. What will be the shape of these? These are of sawtoothed pattern, right? And this particular flutter waves in lead V1, they will resemble the P wave. And what will happen to the isoelectrical baseline? There will be loss of isoelectric baseline. Loss of isoelectric baseline. So these are the features of the atrial flutter. Then how do you treat these patients with the atrial flutter? It is the same thing. We need to give beta blockers, right? And the alternative will be the non-dihydropyridine calcium channel blockers, that is verapamil and diltiazem. So these drugs, they will control the heart rate. But what are the drugs which will control the rhythm? Because in these individuals also you can have irregular rhythm. So the rhythm controlling drugs will be class 3 anti-arrhythmic drugs, right? And this class 3 anti-arrhythmic drugs are ibutyllite or ibutyllite or dofetilide. So these are the drugs which will control the rhythm in patients with the atrial flutter. Okay. Now after having discussed about the abnormalities of the P wave in the arrhythmias, that is multifocal atrial tachycardia, atrial fibrillation and as well as atrial flutter, let me also tell you about the abnormalities of the P wave in case of the atrial. Okay. So you see here, right? What is the abnormality of the P wave you are observing in the ECG strip? So always whenever you are looking for the P wave, you need to look for the lead 2. So you are observing that you are having a normal sinus P wave. Then you have a small P wave here, okay, which is appearing earlier than the next complex. Again, you are having a normal P wave. again you are having a normal P wave, and again you are having a normal P wave. So only this P wave is abnormal. And if you see that the P wave whichever has appeared, it is earlier than normal, and the morphology of the P wave of that this abnormal P wave is not similar to that of the morphology of that particular another sinus P waves. So what does this tells you? This tells you that the depolarization was not from the SA node in this particular abnormal P wave. So in this abnormal P wave, it is atrial extrasystole. Okay, in this P wave, it is atrial extrasystole, right? It is not from the sinus P wave, right? Now, let me just also show you one more ECG here. The question is, comment on the ECG findings below. The options are atrial fibrillation, then atrial premature complexes, paroxysmal supraventricular tachycardia, WPW syndrome. Okay, so the abnormal P waves are marked here. The abnormal P waves are marked here. You see, these abnormal P waves, first point, they are of different morphology. Right? First important thing is they are of different morphology. And second important point, they are appearing, right, that entire complex, it is appearing earlier than normal. Okay? So this we call it as the atrial premature complexes. Right? This we call it as atrial premature complexes. What are the causes of atrial premature complexes? The causes include the individual consuming excess amount of caffeine. Right? Excess amount of caffeine. And the other etiologies of this atrial premature complex will be consumption of excess amount of alcohol, then stress, and individual having fatigue or poor sleep. Okay, so these are all the causes of the atrial premature complexes, right? These are all the causes of atrial premature complexes. Now, let me just also show you, the mechanism of that premature atrial complex, right? Yes, you see this is the normal sinus P wave, this is normal sinus P wave, and here you have the atrial extrasystole, and this atrial extrasystole, that is being represented as the premature atrial complex. And if you take this morphology of the P wave is different, and it is also appearing earlier than normal, right? And the same way, you see the premature ventricular complex. In premature ventricular complex also, you see this is the normal sinus P wave, this is the normal sinus P wave. But for this complex, if you see, you don't have a P wave because the impulse is originating from the ventricle. So, and you are also having wide QRS complex. So that is what is your premature ventricular complex. Okay. So this is about your ectopic atrial rhythm or premature atrial complex. Now, let me just show you one more ECG and let us try to figure out the abnormality of the P wave here. So, first thing, what did I tell you? If you want to look for the P wave, look for the rhythm strip. Okay. And what is the rhythm strip here? The rhythm strip is lead 2. Right? Okay. As in when you look for lead 2, what is the striking thing? The striking thing is that you're having variable RR intervals. Right? You are having variable RR intervals. Once you are having variable RR intervals, what did I tell you? You have that irregularly irregular rhythm. Okay? Irregularly irregular rhythm. So what are the differential diagnosis? Atrial fibrillation, right? Then multifocal atrial tachycardia, atrial flutter with variable AV block, paroxysmal atrial tachycardia with variable AV block. Now, if you take these 4 differential diagnoses, in which particular, okay, you see the P waves. How are the P waves? So in some, you don't have the P wave, okay? And in some, you are having these P waves. What are these? These are nothing but your fibrillatory waves. Right? These are nothing but fibrillatory waves. So this is the ECG of the atrial fibrillation, right? Atrial fibrillation. So same thing we have discussed previously, but I'll let one more ECG for a practice sake, okay? Right. Now, I said you, like in some of the conditions, the P wave, it can get merged with the QRS complex, or the P wave, it appears after the QRS complex. Where do you come across that? Okay, you see here. So if you see the rhythm strip here, this is rhythm strip because this is lead 2. So if you closely observe, in this is a QRS complex, followed by that, this is a T wave, and P wave, it is almost getting merged with the QRS complex, or occasionally it can appear after the QRS complex also. Where do you come across where the P wave getting merged with the QRS complex? You come across this in patients with the supraventricular tachycardias. Right? You come across this in patients with the supraventricular tachycardias. And that too, which form of supraventricular tachycardia? Supraventricular tachycardias, you have many. But in patients with AV nodal reentrant tachycardia, that is in patients with AV NRT, in this condition, you have the P wave getting merged with the QRS complex, or it appears after the QRS complex. And I have discussed in detail about this AV-NRT and as well as AV-RT in the section of the arrhythmias. So you can go through that, right? Now, after having discussed about the abnormalities related to the rhythm, abnormalities of the P wave related to the abnormal rhythms, one question which was being previously asked is the presence of the pseudo-P pulmonale. Pseudo-P pulmonale is seen in, the options are hypokalemia, then hypocalcemia, hypercalcemia, and then hypomagnesemia. Now, what do you mean by the word P pulmonale? Where the amplitude should be more than 2.5 mm. Where do you come across this? In patients with tricuspid stenosis. But in the absence of the tricuspid stenosis, if the P wave amplitude is more than 2.5 mm, we call that as the pseudo-P pulmonale. And where do you come across this? You come across this in patients with the hypokalemia, right? In hypokalemia, you will have this pseudo-P pulmonale. Actually, in patients with hypokalemia, what are all the abnormal ECG morphologies? The abnormal ECG morphologies will be, number one, you will have the appearance of the U wave, okay? And what will happen to the T wave? The T wave, it becomes flat, or the T wave, it becomes inverted. Okay. And another important abnormalities of the ECG in hypokalemia is the QT interval will be prolonged, right? You will have a prolonged QT interval. And another important abnormality, as I was telling you, the P pulmonale will be there, but it will be a pseudo-P pulmonale. So these are all the ECG changes that you come across in patients with the hypokalemia. So this is about your abnormalities related to P wave. So you see the sequence. We have discussed the normal P wave, its morphology, amplitude and duration. Then right atrial abnormality, what will be the P wave? Left atrial abnormality, what will be the P wave? Then in case of rhythms, atrial fibrillation, multifocal atrial tachycardia, atrial flutter, how will be the P waves? And in atrial extrasystoles, how will be the P waves? In junctional rhythm, how will be the P wave? The conditions where you have inverted P wave. So all that we have discussed in this session, right? So with this, I'll wind up this session. Thank you very much.